question for Professor Robin for ALL, transplant versus not transplant in PH patient. The question is, somebody has mentioned you have learned from CML, you were so early allogeneic transplant, then TKI for indefinite period, eventually you reach for TFR, 5 years, then off therapy. Same thing you are learning in the ALL, transplant versus not transplant, and the day will come, you will also say discontinuation of the therapy. What do you think about this?
Well, yeah, again, thank you for the question. Discontinuation, again, we don't really know. I mean, the change in the Philadelphia protocol have been quite dramatic. Nobody would have ever considered stopping treatment. I mean, the only chance was an allogeneic transplant not so many years ago. I mean, it's very interesting this because when you have your fellows in the ward now, and there's acute leukemia, it's an ALL, and it turns out to be a Philadelphia pod, they'll say, lucky, the guy out, the lady has the Philadelphia pods. And now, in our days, that was the worst condition you could get. So things have changed completely. So nowadays, I mean, as I mentioned earlier, in the next protocol, we will reduce patients going to transplant. So that's already a step forward. I don't think all patients need a transplant personally, and if they have what we just discussed earlier, that very good biological profile response, these patients will not go to transplant even if they have a simple donor. But they have to be monitored very closely by MRD, obviously with the most sophisticated technologies. Now, stopping treatment is obviously something we don't know. I mean, it's not like CML yet. Maybe, but what I can say that in general, we have patients that are living with Philadelphia ALL only on a TKI. But so far, it's very rare that you stop unless there's toxicity, obviously. I think it's too early to say. I hope to see the time when this may happen, because at some point the patients, I mean, but it's very clear that now we can obtain in a high proportion of patients, we can obtain a very profound molecular response. So if this persists for a long time, then I think we will enter, hopefully, a stopping treatment era, which would be another turning point.
Interestingly, our data from Tamam Hospital over the 4 years, when we send patient US for allogeneic transplant, they put ponatinib. When we send UK, they put imatinib and transplant, both transplant. When we send India for transplant, they don't do anything, they just put Gleevec in ALL. So different country, different profile of the treatment and different choice of the TKI. And as Dr. Teferi, I was very happy to hear from him that he told Gleevec is the best choice rather than as Dr. Marashi knows, we have now generic medication which is $100-200 versus $3,000 to $4,000. So especially this is good for those people. This is really good rather than just moving second generation, third generation, just quick decision, unnecessary, no benefit. So this is a common question with everybody. What do you think? Different area, different decision, and different world.
Well, if I can make a comment on this, I mean, clearly the situation is very different between CML and ALL, Philadelphia Project. We would like to reach the situation where we are in CML. I mean, to see the curves of patients living like the normal population is something, again, that in the old days would have been a dream. So that is a major change. So in the Philadelphia Project, it's very different. I mean, we have to consider different points. I mean, clinical trial is one story, real life is a different one. Now, we in our country, we can't give drugs off label. So if we have to stick with the rules. And in that respect, imatinib is the only drug approved, only TKI, approved for frontline treatments. We have no choice if you're out of the protocol. So imatinib is okay. It has a less debulking effect, as shown also in vitro. Just to give you an example, and I think I said in one of my talks, if dasatinib, with only dasatinib steroids, we get between 20 and 30% molecular responses alone. Then with bleed, it goes up. But ponatinib, it seems to be higher, but in our GMEMA study, it's submitted now, it's about 50 or 60% only ponatinib, more toxicity. But again, I mean, ALL is not CML. So since CML, quality of life toxicity is something one has to consider. In ALL, you have to consider curing the patient. The main endpoint has to be MRD negativity with frontline treatment. So I think it's very different, and we have to use what is more active. Now, in next protocol, it's going to be ponatinib and blina. because we hope that at 80% we reach maybe even higher MRD negativity. We pay a little bit of toxicity, we know that. We can give lower dose, and Dr. Teferi was mentioning that's what we plan to do. But we have to obtain MRD negativity. In CML, it's a different story.
So here everybody would agree with Dr. Teferi, like, in the CML actually, Gillivac is the best. What do you think? Preference level. As he meant number one, I would heartily agree with him. Dr. Marashi would agree with, because we pay only $100 rather than $5,000. It's cost. It is not drug toxicity. It's cost effectivity, and short term, long term side effect. In future, it will come like this. Yeah, Doctor.
Again, yeah, you can. Now, I don't want to take the scene. I'll be very short. I think you can read this in different ways. I totally agree, and I think it's very important that Dr. Teferi mentioned something I'm very close to, is the fact that costs were a key point. I mean, I remember a girl coming in one day to our office, and she said that in her country, she couldn't even get Gleevec because she was only 27, if I remember, and 50 years of Gleevec would have been unthinkable. So they offer a transplant. This is happening around the world. You can't get the inhibitor, you get a transplant. I mean, it's dramatic, but this is happening. Having said that, some colleagues dealing with CML would say that if you have a likelihood of stopping treatment, then many would start with the second generation. So you can read it in different ways. It costs more, but we're the national health system. So if the drug is approved, we are allowed to use what is approved, irrespective of cost, until we don't go completely bankrupt. But that's a different story.
And in this instance, I think the state has done you a favor. So by forcing you to use, the safest drug, which is cost effective, and so forth. In regards to what you said, the reasonable concept to consider that if I started with a more potent drug, maybe I can stop earlier. That's fair. However, what is the rush? You can start with imatinib, then you go on for 3 years of deep molecular response as opposed to 2 years of deep molecular response. You can probably go there at the same time. Again, the problem is, if I was a patient, I don't want to risk getting peripheral vascular disease or cardiovascular event or anything, just because I feel very comfortable with CML at this point. That I know that I can go to these drugs if I fail imatinib. So I don't see the rush, and I don't feel that the risk of this untoward effect is justified just because of quote-unquote potency. I can get there faster and deeper. So that's my 2 cents about it.
Can I comment 2 things here? Most important thing is, you are right, cost. Suppose, as I mentioned, 2-month cost equal to almost a year or 2 years. This is one thing. And more important thing, have you noticed, discontinuation therapy have more Gleevec based proven rather than dasatinib and erlotinib, second generation. So they have more data, more, good data. So, what does it make difference if we can get, MR4 like within 3 years or 4 years, just saving a lot of cost. We should be realistic. We are scientists and economists. We should save money to the country as well, not just to be a bankrupt. Then we realize, we use all money with the second generation, third generation. Why not we shoot first generation? Like,
yeah. Ahmad, I am really surprised. I'm very surprised that you can say those things, which is proof, without feeling, any kind of forthcoming from the pharmaceutical companies. Because here in the United States, a lot of people, they're very good. They're as good as you. And they have as good common sense as you have. But they won't say that because the research and everything is dependent upon all these pharmaceutical companies. And I don't fault Europe, especially Italy, because the state and the government doesn't care about the scientists. They don't care about the hematologists. They have to get some money from the drug companies if they want to survive and continue the science. So I appreciate all sorts of things, but with you, Ahmad, since you have the flexibility and you don't have to bow down to the pharmaceutical companies. I'm very happy and I'm very proud of you being very strong on this.
Thank you.
Actually, we follow best practice when we have a patient who has put trust in us. So we have to make sure that that trust is justified. So we have to look always at the best interest of the patient. So I think whether we say it loudly or we don't, we put the patient's interest number one. So that's the important thing. Just there's a question, well, I'll take this point and I'll let Dr. Shahrukh take and ask the question. I want to ask you, the push was there that you should give, if you get an early response, quicker response, you are avoiding the risk of transformation, which is a bit higher with imatinib, and then you are able to get a treatment-free remission. And there was a suggestion that at least for 3 months to use second generation and then go and follow up with the imatinib. What do you think is the sense in such a thing?
What I think is marketing. They want to sell their drugs. So they will always try to find ways of infecting themselves. So this is just another tactic. Okay, fine, but let's go first 3 months. I think you can make money in the first 3 months. Maybe they will forget and will just continue after that. This is all marketing tactics. And there's as long as there is money, there's always somebody to appease you. They will do the study for you. They will do the. So I think that is simply a marketing tactic. I have absolutely no for that kind of tactic.
I endorse you. Please. Go ahead. Yeah.
No, but mine was just a joke because on these lines, I always, in fact, tease my CML friends saying that it's amazing how they manage to continue to do research and develop this and the next. I mean, let's be very honest, CML problem is almost solved with imatinib. That is the real fact. Then you see fantastic studies and you see this tiny difference. You can always do sub-analysis, this, sub and the other. In a disease where, I mean, to be very honest, there's not very much still to discover. And yet you see how it's going. So just to follow as a comment on what you were saying, which I agree.
So your message is hidden. Professor Robin's message is hidden, but Dr. Jeffrey's open message. The message is same actually.
Dr. Shahrukh will take over to ask the next question.
Yeah, thank you. I think we're at the top of the hour, so we have time for only one question. So there's a question from the audience. I think this will be to Dr. Teferi. There is a case of post-ET myelofibrosis, supposedly low risk, age 45 years only. When do you perform allogeneic bone marrow transplantation in this case? Dr. Teferi.
Very good question. It happens. Fortunately, the risk of going into myelofibrosis for true ET patients, clearly WHO classified less than 1% in 10 years, less than 5% in 20 years, but it happens. When it happens, you have to ask the question, is it really post-ET myelofibrosis, or was it a prefibrotic myelofibrosis that was misdiagnosed earlier? Regardless, we apply exactly the same rule as primary myelofibrosis, meaning if they are genetically cursed, meaning they have this ASXL1, SRSF2 mutations, or they have a karyotype which is high risk, monosomy 7, for example. If they are genetically cursed, you need to transplant those patients. You don't wait at all. Now, if they're not genetically cursed, meaning that they are genetically okay, JAK2, or genetically blessed, if they have a type 1 CALR mutation, if they are genetically favorable, and then we look at the other things. Hemoglobin, is it less than 10? If not, that's a good thing. Circulating blast, is it more than 2%? If it is less than 2%, they're good. Constitutional symptoms, are they looking reasonably good? They're not hectic? That's good. So if all these clinical parameters are in the favorable lane, and they are genetically not cursed, then there is no rush into transplant. But if you find bad genetics, then you probably should transplant. Otherwise, you can monitor the patient. And now, you guys, Shahrukh, you do transplants as old as age 75. So age is not an issue. And considering that, there is no urgency. And we hope that while they wait, some better drug will come that would make the transplant not necessary.
Well, thank you. That's wonderful. That's such a comprehensive answer. It captures a lot of aspects. So thank you, Dr. Teferi. We are making a bone marrow transplant center in UAE with the help of Mayo Clinic.